Hello everyone, my name is Eugen Buga and I am very glad to meet everyone online on this extremely special webinar about this such important topic on the conservative endodontics. And the title is, as you see, it's less is more. And we will cover today how important it's to maintain the tooth structure of the tooth in terms of preventing the mechanical failures. Because nowadays, when we talk about the successful endodontist, everyone is able to perform a root canal treatment in terms of instrumentation, creating a white lines, because the metallurgy nowadays is quite good. The resistance is not bad. Well, of course, it depends on the file systems. Some of them are better, some less, but most of them are quite flexible and resistant to torsion. It means there is no problem with the instrumentation of the creating of the white lines. The problems occur when the patient come back with the coronal fracture, and we start to think what goes wrong. As you know, the endodontics, it's not always just the white lines. What you see on the X-ray, it's always the obturational material into the root canal space, which was placed by a previous doctor. And somehow, at the one point, it goes in the wrong direction. Because having a big, fat, white line was associated with the success, with the good, so-called good, fitting the standards of the contemporary root canal treatment. And unfortunately, running on this way of creating a white lines, the young dentists, the old school dentists, don't care about the pericervical dentin, tooth structure, coronal portion, and what we see usually it's very nice white lines. These are some of my cases, and I was concerned about to have these white lines to be up to the end, all the canals, even a nice puffs, because I had the idea that what is coronally we can fill with the obturation material and everything will go smooth. It can run, but on the long term, as you manage the practice, you see most of the cases failed because of the mechanical failures. And nowadays, I'm more concerned on the preservation of the tooth structure, and I'm not concerned just on the white lines on the roots. But I understand perfectly, at the beginning, all of us are concerned just about to reach the end of the root, to have good filling into the roots, and later we will place a filling. That it's completely wrong. Completely wrong, because you can see this is one of my cases I did before. It was about 7 or 8 years ago. A big lesion, a big cyst, a root canal treatment up to the in this case was DCTaperH 2006 up to number 20 ISO, the taper 06. The instrumentation, quite conservative instrumentation, but take a look at the coronal structure. So it's quite compromised mechanically. The treatment was done. The follow-up after 3 years, we can see the healing. It's going well. But unfortunately, what we don't see later with the years is this. You can see this case, it's absolutely out because of the fracture. And Somebody of you will say because there is a breach, it's overload. Yes, it's overload, but still, the lesion healed, a big, huge lesion healed, but mechanically there is a failure. And here we have to make a big emphasis how to prevent these failures. Because as I told you previously, when you want to be a good endodontist into the town and you want to convince the general dentist to refer you cases, you have to convince them that you are better than someone else. And doing this just with the white lines, it's not enough, because nowadays most of us can do a white lines. It's more important how much you can prevent of losing of the tooth structure, to be more conservative, to be more patient-oriented dentist, and not about process-oriented. It means smaller cavities, smaller preparations, biologically oriented. And think biologically, think about your enemy, where is the irritation into the root canal, how much you have to cut, and every step need to be driven by science. One case, this is case of mine performed some time ago, when I was just concerned onto the roots, and how the maestro David Clark says the prosthetician always think about the coronal part, the endodontists always about the root canal, the root part. And this is somehow wrong. The endodontist need to think about the pericervical dentine, ferrule on the soffit, and the prosthetician also. Nowadays, I am more concerned onto the pericervical dentine. I'm not so aggressive with the instrumentation, and I don't over enlarge. It depends on the diagnosis and clinical case. Talking about minimal invasive endodontics, need to be clarified very well that more relevant, more correctly is to say conservative endodontics, because it's not about to be as small as possible. It's not a competition. It's a result-oriented treatment and approach. It means preservation of the tooth structure there where it's not necessary to destroy it. And nowadays, the more appropriate term is directed dentin preservation, because usually the bidimensional image of three-dimensional object confuses us. What we see on the X-ray now, we see just so-called root canal onto the root. In fact, this is so-called as we know, radiographic mental model. This radiographic mental model suggests us that usually on this area, onto the inner area of the curvature, we have less dentin, less taper, and more concavities. And being aggressive with the preparation, using inappropriate instruments for a shaping, and here when I'm talking about inappropriate instrument for a shaping, I'm talking about ordinary rotary files which are done from the wire with a diameter 1.2, quite big, and not so good for such conservative phases of the treatment. Because when we're talking about the dentin preservation, we have two very important structures. It's a ferrule and a pericervical dentin. Being concerned about these two structures, making us to be more secured in terms of the mechanical resistance. And if we talk about the coronal portion of the tooth, it's a well-known the pulp chamber soffit, wherein the architecture, a soffit is described as the underside of the ceiling, at the corner of the ceiling and wall. And the chamber of the young molar tooth is bounded by a roof, 4 walls, and a floor with a small orifice that arranged along the edges of the floor like pockets along the pool table. This structure is quite important into the resistance in terms of mechanical stress. And unfortunately, just in endodontics, you can find some articles, some science supported by some companies, when they try to convince you that destroying the tooth, it does not influence the resistance of the tooth. And we know perfectly that more structure will lose, less resistance is the object. It's from engineering. It's simple. You can see in this case, it's a case of pulpitis. The preparation of the cavity was done using access kit from SS White, and this is the microsurgical board to adjust the access. The instrumentation, I just need the holes, the orifices to put my rotary files in and just to go with the instrumentation. I don't care about the interferences with my rotary file, because nowadays the metallurgy and the design of the rotary files we have, it's very, very, very good to resist to this stress. Don't worry about interferences. If your rotary file systems are breaks, it's because of the wrong rotary file systems. And not all the rotary file systems are the same, as you know, because the flexibility, it's not just one of the points. Being a torsional resistant, it's the second, and in my opinion, the most important ability. And one of our webinars, we will cover the instrumentation principles, and you will understand why not all the rotary file systems are the same. And you can see, using a magnification, I can control easily the mesiobuccal canal. I see the distobuccal canal, and I see the palatal canal. Somebody will say, no, it's quite small for me. Well, you need to understand clearly that the endodontic access have some rules, how it created. And it's not about the size. It's a dynamic process, and at the beginning of the career, your access maybe will be a little bit bigger just to be more confident with the control of internal anatomy. But later, you will understand that you just don't need to cut as much as you do usually just because the canals are not there. And it's not about easier to make just a restoration for you. It's more about care for your patients, the patient which will generate the new patients. Easy instrumentation with the soffit preservation. You can see on this image. Preservation of the soffit. On this long-term retrospective study of clinical performance of fiber post, a nice study performed by Marco Ferrari and co-authors, the mechanical failures were always related to the lack of the coronal tooth structure, which means that we don't need to fix with the heroism the problems, we need to prevent them. It means to stay conservative. And doesn't matter it's initial treatment, it's a pulpitis, or it's a retreatment, just remove as much as you need to reach that area of the irritant. It's not about white line to feel your ego, to make a post on the social media, to feel the let's say the social standards, because it's not about the Facebook dentistry. It's more about your real practice dentistry, where we generate the quality, where we generate the patients. And meeting the standards of the social media, you just create perfect conditions to fail. A huge root canal preparation, a loss of the coronal structure loss, which lead to the failures. And as Donald Downs says, the biggest risk factor in tooth retention is dentinal tubule amputation. You can see in this case, it's a case of pulpitis in the upper premolar. The preparation, the access refined using the endoguide microsurgical burr. Refining the access, making the instrumentation just as large as you need, because it's the pulpitis, the irritant, the bacteria, the toxins are coronally, so you don't have to dig as much as you think. You need to go apically because the irritant is there, it's coronally. And the complications, the failures with the periapical lesions and inflammations are related to the presence of the bacteria and not the presence of the small preparation or big preparation. And when I'm talking about the conservative files like a DCTaperH, I'm working with them for more than 5 years. And working with the DCTaperH, it's not, let's say, old school commodity. It's more about safe, fast, and conservative preparation. This is a sequence I use usually. The glide path files I'm using more in case of mesiobuccal 2 canal, but it's another topic we will cover in one of the webinars. The glide path files also I'm using into the calcifications or in the middle mesial canals or additional anatomies or C-shape anatomy where I don't want to be aggressive with the preparation. But 90% of the cases I'm going directly with my shapers. It's a white, yellow, and red. And if you take a look at the taper, all 6, it's a different story. It's not as regular files, and later I'll show you why. Because here the taper, it's all 6 in the first millimeter, then the taper goes to 0, which means we preserve a lot from the coronal structure. It's not about the flexibility just. The flexibility is just a good bonus as an addition. But the main factor, it's a conservative coronally, and it's a very, very torsional resistant, which means the breakages are related to almost 0. This is the differences between conventional files and the DCTaperH. The differences are into the diameter. And if you can see the wire from which is made, the 20-wool-6, the yellow one, the 20-wool-6 onto the DCTaperH, it's 0.8 of millimeter. Regular files onto the market are 1.2, you can see on the ProTaper lower. So it means from the coronal portion you destroy a lot just because this is the design of the file. And you don't need to cut that much because it's the pulpitis, because it's the retreatment and all the irritant. It's apically, you need to be efficient there and not coronally. Coronally, you are quite efficient enough using the instrumentation, using the irrigation. Apically, there is the most important part, as you know. And having a good control of orifices, you can see the mesiobuccal canal, you can see the distobuccal canal, you can see the palatal canal. So I just cut it as much as I need to control the orifices and the instrumentation of the internal space. Here is the obturation. Here is the final X-rays. You can see as much tooth structures was preserved. And again, it's not about to be that conservative. It's about to be more and more conservative day by day. Start with the conservative rotary files, which you can just switch from tomorrow using a conservative files and preserve a lot of tooth structure. Of course, not always we have intact teeth. Usually we have fractures, we have a retreatment, and even in the retreatment, we have to be conservative because the more two structures we have, better the prognosis. Which one you will have a better prognosis? The left, right? The left one, right? On the right, even it meets the so-calling standards with a good obturation, which usually people associate with the good irrigation. In fact, it's just hydraulic forces push the obturation material. In my opinion, this case have higher chances to fail because of the lack of the two structures. And you have to think a different way. Don't be lazy to prep a special access for a root canal space, as on the case on the left, on the upper molar. You can see the cavity is treated separately, the access to the root canals, instrumentation, conservative instrumentation, and a good future for this tooth. Suggested the crown, but if the patient for some reasons is not able to do, still better chances for a long-term success in comparative with the case if we will destroy it more, we'll make the access connected with the distal lesion. Well, the endodontic access, as you know, started from long time ago, different names, and somehow it stopped at the one point with the straight line access when it was suggested to have a straight line to the orifices. In fact, it's quite wrong to follow that standards, that old standards, when the doctors care about their patient. But in fact, if we will go back in time, we understand perfectly that did not have magnification, no radiographic control. They even have old design inverted rows, large burrs. No flexible files, no microsurgical burrs. Nowadays we have everything of this: magnification, radiographic control, flexible files, and microsurgical burrs. So it means we can go better and we can preserve more tooth structure, doing the same fast and efficient job. You can see the incisors, the axis didn't change at all with the time, the same cingulum axis. And we know that nowadays the concept is completely different. Straight line access to the curvature. You know, I don't want to say that a lot of science is influenced by some interests, some companies or someone. But what I'm trying to say is that when somebody suggests to make a straight line access to the orifice, to the curvature, it's somehow to protect you, to avoid breakages of the file. But nowadays, as I said previously, we have a very good rotary file system which don't need this facility. The glide path up to number 15K file, well, it's not needed. Just 1K file to measure the working length, that's it. Somebody will say, I'm more friendly with the glide path up to number 15K file. Well, you can do that. You can go even with the number 20 or 25K file, but it's waste of time. It's extrusion of the irritant. You increase the number of steps of the instrumentation. You increase the chances for iatrogenics. For what? To make easier path for your rotary file. Nowadays, rotary files we have on the market are very efficient. Well, if your rotary file system doesn't match these requirements, then just switch to the better one. But you waste a lot of time with the procedures you don't need to do. With the magnification, with the radiographic control, flexible files, and microsurgical burrs, it's the complete start pack to become more conservative. And it's not necessary to become conservative just when you will have the CBCT or X-ray machine or a microscope. You can start it from today just with the conservative rotary files, then add the microsurgical burrs, then magnification. And as I told you, it's not about the standards, a small orifice through the coronal structure. No, it's about avoiding this losing of the tooth structure when it's not needed. We have flexible files, and you will see the nice microsurgical burrs we have, which have a good centering. And when we have a calcification, we just turn on the water, we have the magnification, we prep little by little, good centering. We don't using ultrasonic tips, because ultrasonic tips scratch the dentin, burn the dentin, and you will always be directed into the wrong direction. But it's not about the calcification. It's more about the webinar, more about the conservative endodontics, and we discuss about how to make your practice more successful and to have a very well designed protocol with the access and instrumentation and clinical thinking. Straight line access, let's imagine we have a straight line access, we have a preparation for a crown, and you can see how much we lose from the tooth. When we have an orifice directed access, we preserve a lot and much more from the ferrule and from the pericervical dentin. And according to David Clark and John Cademy, two giants and the conservative endodontics, the epiphany of the Clark Academy, it's the importance of the tooth structure. And as you can see, the high important role is the pericervical dentin, axial wall, and the cervical enamel. All of the tooth structure around the orifices are important, extremely important, in the long-term run. Orifice-directed access, you can see how it can be done. You have a case, and you have the pulpitis after the new filling. You see the curvature, the difficulty of the curvature. That's it. You have the orifices. You can control the orifices. You don't need more than that. You just identify the orifices, check the working gland, make the instrumentation, irrigation. Somebody of you would like to make the activation also. You can just run away. And save the tooth structure. And when somebody says that it's dangerous for rotary files, think twice, because nowadays the rotary files are very resistant, as I told you. This is a 3505 rotary file. Yeah, it's the DCTaperH. And as you can see, even on 90 degrees curvature, banded coronally, it can rotate easily into the canal. And on the patient with the limited mouth opening, it's just perfect to have that ability of the rotary file system. You can see the shaping, you can see the final obturation. As you can see on the X-ray, there is a soffit preservation. That's because I don't need to cut more to make an instrumentation, not because I cannot destroy the tooth. If I will make larger, I will be able to do it easily, they say. Well, if you cut the coronal portion all, you will do it easier. But it's not about easier, it's about to train yourself to have a good tools to make it easy by itself, preserving the tooth. And now the question is for you. Do you want to go to the next level, to work on yourself, to be more conservative, to be more centered on the success on the long run, or just you are a sprinter, making a good image, posting on the social media, everyone is happy with the instrumentation and irrigation, and the patient failed, the case failed. And somebody will say, well, my cases does not fail mechanically so much, because I see very small amount of patients come back with the fractures. Well, it's just about patients who come back to you. A lot of them just go to another doctor. because it's failure. And we want to reduce this number to the minimum. Morphology driving design, it's a design elaborated to prep accordingly to the anatomy. And as I told you, it's not about the small axis, it's about directed dentin conservation. Restorative leverage design, it's, as I showed you a case previously, we have a lesion, we have a decay, we restore the decay, we make a separated access, and we make an instrumentation and filling. And on this case, on restorative leverage design, you can see clearly with a huge defect on the distal area, restored, make an access straight to the orifices, instrumented, filled. Coronal restoration with a prosthetic crown, it's suggested. The same on this case, lesion, restoration, access, instrumentation. A crown is suggested. We always suggest a crown after the root canal treatment, but we understand perfectly that our patient not always are happy with this idea, financially especially. And if you will be concerned about the preservation of the tooth structure, some of your patients who will not do a crown because of some reason, hesitation, financial problems, personal issues, or something else, will keep in mind that he is absolutely okay with that tooth which was treated by you. In all the scenarios, you have better chances for a good outcome when you are more conservative. Lesion on this premolar, thinking outside the box, you have a direct access to the root canal space, performing the adjustment of the access to the root canals using the microsurgical burr, it's EndoGuide 6. Measure the working length, the instrumentation. Instrumentation, as I showed you previously, even after about the corner, you can do it safely without worrying that the file will break, because the metallurgy is very resistant. First, at the first stress of the file, you will have unwinding of the file. That will be a sign for you to change the file. If you will change the unwinded files, you will never break a file. Of course, saying never, it's more about almost never, because you may have some cases with a limited mouth opening of the patient close when you rotate, or you are not so experienced with the new file system at the beginning. You will need some time to go through this learning curve. You see the buccal canal, you see the lingual canal, filling and obturation. Being conservative with the root canal space, keep these tools for a long run. The instrumentation was finished with a 20-06. There is a pulpitis, the irritation, it's the coronally. There is no irritant apically, it's not need to destroy the coronal structure. It's another case, it's the lower molar, the instrumentation up to 25-06. And you can see as conservative it goes with the pericervical dentine, with the soffit, the access. Caries and morphology directed design. It's when you have a huge tooth with a interesting morphology, I'm saying a very wide position at roots, mesial compared to the distal, and you just make a separate access to the roots, and this way you will keep this truss, calling a truss access, and you can make the instrumentation without connecting these two accesses. destroying the tooth. Final obturation. And here is a case to show you. You can see the lower molar. I can just destroy the tooth, fill with the composite later, and don't care about the result on the long term. But as I told you previously, I go through all these steps when I was more concerned about the root canal space. Now I'm more concerned onto the preservation of the coronal tooth structure, also in pericervical dentin. Cleaning, excavation, and initial preparation using a diamond bore from the long diamond bore from the Access kit from SS White. The preparation, adjustment of the internal space using the endoguide burr. So guys, if you have an opportunity to work with the endoguide burrs, just buy them and you will never regret. I'm saying that as always on all my courses and conferences, absolutely honestly as always, because when we are looking for a microsurgical bore, what we need is to be a very well centered. When it's rotate, it cut just in one point, not making these circles around, and very cutting efficient. That is why the magnification is required to see what you cut, and it stays for a long time, and they're very, very resistant. The instrumentation into the mesial system, the middle mesial, the distal canal, and you can see the obturation, the truss preservation. As I told, always recommend the crown, and don't think that if you will place a crown, the result will be the same. So Eugen, if you make a crown, what is the reason to be that conservative? So as I told you, when we talking about the prosthetician, they think that everything it's white inside, it's the tooth structure and not composite. So they cut as much as they want, they place a crown, and the tooth will fail. If you have the structure preserved, you have a truss preserved, and the pericervical dentin, the outcome on the long term will be better. Conservative retreatment. Here you can see the case on the premolar. The truss preserved accidentally, I suppose, by previous dentists. I don't care about this truss, just instrumentate the root canal space and keep the truss there, because it don't affect my instrumentation at all. Final obturation. And yeah, we know there is no reason to make the small access, going with the round bores inside and pretending you are very conservative. Yes, as we know, we need the magnification, you need to see what you cut, you need a good light and a good armamentarium. When we're talking about armamentarium, we talk about microsurgical bore, about the endodontic files, conservative endodontic files. And don't be afraid to start to become conservative. It's always a learning curve. And as you know, with our motto, it's to be tomorrow better than we are today. And with every case, with every failure, you will be better and better and better. And you will move to that 5% of the dentists who are very patient-oriented dentists and care about to be conservative, not just about white lines. Access to the incisors, classical one to the cingulum. And every one of you who work with the microscope know that when you have the classical cingulum access, you will not be able to see the canal, which means that it's a little bit old access, and nowadays the access need to be a little bit shifted more to the incisal edge. Cingulum access versus orifice directed access, you can see as much tooth structure we are able to preserve. And if you're worrying about the incisal edge, just make the access close to the incisal edge, not to compromise the aesthetics if you are worrying about the incisal edge. This is the cingulum access. You can see on the CBCT how much we usually cut looking for a canal with a round bore, but on the bidimensional image we never see that. We just prep the crown, the coronal portion of the tooth to make a crown, and what we get at the final, the crown and the mechanical failure. To be in that situation, it's a bad idea, because aesthetically failures move us to the and lead us to the a very disappointed patient. And trying to resolve it with the implants, every implantologist will tell you that having an implant in the aesthetic area, it's not the best scenario. It's quite difficult to work with the soft tissues. That is why we're concerned about our patient. We are modify our access to the incisors. We are switching to the more conservative, straight access, orifice directed access. On the young patients, be careful because of the prominent lingual curve. Your orifice directed access will go through the buccal part. And if you worry about the aesthetical component, just make it through the cingulum more vertical, directed to the orifice. Okay, and on this molar, as you can see, the instrumentation was done conservatively with a 25-06 instrumentation. Somebody will say 25-06 is huge preparation. Not. 25-06 DCTaperH, it's conservative file, which it's 25-06 just in the apical area. Coronally, it's very conservative. It's a wire 0.8. And here you can see this premolar. This premolar, which lead us to the idea that always being aggressive with the apical part just because you are thinking that in that last millimeter is all the irritant, you are a little bit wrong, because one canal have from 1 to 29 portal of exits from the to the root. And looking at this micro CTs performed by Brazilian group of researchers with the Marco Versiani, you can see the perfect illustration of the apical end. The apical end, it's very surprising. It's a difficult anatomy which rotary files need to handle. And if you're using classical rotary files, you always will have ledges, you will have a transportation, you will have another iatrogenic errors. How many of you have these nice lateral canals? Never, because our rotary files, it's not able to instrument that area. That is why it's not a reason to push with your rotary files over the apex and to try to disinfect better, because the real disinfection, it's performed by your rotaries. You're using 2004 or 2504. I'm much more efficient with the 2006 or 2506. At the same time, staying conservative coronally. And here is a nice illustration of the histology by Domenico Ricucci, a just outstanding researcher, independent researcher. Here is the histo of the tooth affected by decay. And you can see apically there is the absolutely vital tissue. You have nothing to instrument it there. Your rotary file will never go in all the anatomy. Don't be aggressive. And what is the quality of the tissue into the root canal? The bacteria are there or not. And here is the nice study performed by Domenico Ricucci and Jose Sequeira, where They analyzed the fate of the tissue and lateral canal and apical ramifications and pathologic conditions. They screened it for a presence of the lateral canal and apical resistance and the quality of the tissues. When we have a vital tooth, there is a pulpitis, we have a vital tissue inside. If we have a decay, the tissue in the apical area and the lateral canals are still vital, just in case of pulp necrosis. We have partially or completely necrotic tissues. That's why, in conclusion, that obturation of the lateral canal, it's not an evidence of excellence in endodontics and was not supported by literature. All the lateral canals we see, it's not because you are very efficient with the irrigation, it's more about the hydraulic forces of your obturation. And rotary files need to be prepared to handle any anatomy. Here is the bidimensional image of the lower molar. And what we see, the same lower molar from the different angle, you can see as difficult is the internal anatomy. Rotary files, not just conservative, also very flexible and resistant to torsion, and at the same time safe in instrumentation. We just change the file when we see the plastical strain, the deformation. Saves a lot of money and very convenient for a long run in your office. When we move to the instrumentation of the root canal space, there are a lot of techniques suggested to be used, different names, different authors. In my opinion, the instrumentation of the root canal space needs to be done based on the science we have, as simple as possible. Because the only thing means in our office is the success rate on the long run. And the basic techniques I'm using is the full length sequence, with the hybrid technique, and in the retreatment I'm also adding the crown down technique. Being conservative with this technique, it's very easy. When we have a regular case, we have the working length established, we make an instrumentation. Just after first K file, we know the length, we go with the rotary files. In my case, it's DCTaperH. White, yellow, red, you decide when to stop, based on the diagnosis, based on the internal anatomy, based on your beliefs. But we don't care about S-curve canal or a J-shaped curvature. We just put the file in and go to the length. Final obturation. Here it's, in that cases, with the full length sequences, we just elaborate the access, orifice directed access. We have the orifices, we measure the working length, we go with the rotary files in. That's it, without any brushing insides, without any pull out motions and so on. Because with every motion you are doing up and down, you not just cut a little bit coronally, you also push a lot of irritants apically, which may lead to the postoperative pain. So staying conservative, it's not just about the tooth structure, it's always about the patient. And staying conservative with the instrumentations means the less postoperative complaints. Hybrid technique, it's the technique I'm using sometimes when I need to use something, some hand files, some K files by hand. And in the webinar of the instrumentation of difficult anatomy, we covered, and we will cover again this topic more deeply, but this is one of the techniques I'm using in my practice also. And you can see the conservative thinking in this case. You can see the mesio-buccal canal enlarged up to the length with one file, with the mesiolingual canal, because they are joining, the instrumentation was done up to the connection of the mesial canals, and you can see how conservative it's there, the preparation. And the retreatment, I'm using the crown down technique. And why I'm included on this webinar the conservative approach on the retreatment, because in the retreatment it's also important how much you can preserve from the two structure, because usually in the retreatment it's the compromise case. And on this case, with the broken file inside, you see after the curvature, the same protocol for instrumentation, we eliminated the obturation material up to the point of interest, up to the broken file. We switched to the hand file, managed the broken file, we have the working length, and what we do after that, we just go with the rotary files as in the full length sequence. Rotary files, which one? Again, follow the instructions. And most of the instructions says don't use the rotary file in the presence of the broken file inside. Yes, but not in my case. Using a torsional resistant files as a DCTaperH, I have that control and save on the instrumentation. When I heard that metal sound, when my file goes near to the broken file, I just remove it, clean of the debris, and inspect the file. If I see a plastic deformation, just throw out. And at the end, I'm able to instrument the canal up to the length. You can see with the irrigation the file goes out. It was not my intention. It's absolutely crazy. Try to remove this broken file. It goes accidentally somehow. And the obturation. It was possible to go up to 2006 up to the end because it's the design. It's a conservative design in the coronal portion, and it's more flexible and more resistant. And that cases when you have a difficult anatomy, you have some obstacles into the canal, you need the rotary files which will be quite flexible, resistant to torsion. Because as I told you, having a very efficient apical preparation, it's what we need. And in this case, you can see this lower molar, the distal canal, it's quite aggressive curved. We used here 25-08 because it was a wide canal. 25-08 and such curvature. Try to do that with other system. It's impossible. Well, you know, you can go in such anatomy with a smaller one. You will still be safe. Let's say 25-04 or 20-04. You will be safe, but apically I will be more efficient. Somebody will move to the next size 30, 35 K files. You can, but with the K files, with the stainless steel K files and such curvature, it's a high incidence of creating of a ledge or another iatrogenic errors. Staying conservative, you can, doesn't matter what kind of anatomy you have. You just prep the orifice directed access, you go with the file, the K file in with the working length, and just go with the rotary files with the white, yellow, red. Final preparation, final obturation. And here is the quite a long period recall. It's a 3 years recall of the case. Still everything is fine. The tooth is still there, asymptomatic. Fortunately, in our clinic, we are able to see a lot of cases, the recalls, because we have a lot of orthodontic patients. We come back time to time because with the other patients, it's not that easy to follow them, to see all the cases. Somebody are afraid about the breakages with the limited access. Well, these are two exemplar studies where the authors comes to the idea that 5% of the files breaks at the first use. Well, it was 2004, 2005, both articles, but nowadays with the new files we have, we are safer, we are faster, and we are more efficient and stress-free because of the breakages. That's the problem with the results, with the management of the cases. Our ego, our tendency to have a bigger white lines, to have a more irrigant there, because somebody told us that having a more irrigant means more success. No articles or studies to support that idea. Having a bigger white lines means you are better in instrumentation. Having a nice puff periapically means you have a good irrigation. Not. Correlation doesn't mean the causation. What really matters for us is to keep the patient tooth for a long term. And don't think about the missed anatomy. You always will be able to control the main anatomy. Conservative access to the crown, we can see the distal buccal, the mesiobuccal, the palatal canal, all the canals easy to see and to control, to instrument. The instrumentation through the conservative access, predictable, because we have files which are resistant to torsion. A case, the access, you can see all the C shape there inside. You instrument all the length, you obturate missed anatomy through the conservative access. Well, the smaller the access, the better your control need to be, of course. But if when somebody tell you there is the missed anatomy, it's because he have no idea what anatomy means. The anatomy is a complete root canal space inside of the tooth. And having a missed anatomy, you always have the missed anatomy, but not always have a failure, just when you have the irritant, the bacteria there, enough. And what we do daily, we instrument the main anatomy, then time to time see, and we are able to instrument additional anatomy, the smaller spaces, canals. But what really matter for our patient, it's a symptoms-free tooth, functional and asymptomatic. Here we have a molar, we have a nice obturation, and if you will see this case in your practice with that obturation, you will say, well, it's good enough, there is a missed anatomy. No, I don't think so, but I will show you this case from a different angle. Yeah, this is a different angle. What about another canals? Is there a missed anatomy? Well, we cannot call this missed anatomy because we always have a missed anatomy, more or less. Yes, somebody will say, well, we are talking more about the main anatomy, main canals. You never know what is main. What you see onto the root canal or onto the X-ray after the obturation, it's your obturation material into the space you prepared. If there is the oval canal or it's a C shape, you never know where you are. So we just instrument the main anatomy. How to clean up the access? There is nothing special with that. We are using the ultrasonics. We just fill the access with a hypochlorite, and you can play there with the ultrasonic as much and as long as you want. Okay, irrigation from one part, then using the ultrasonic tapes to play around. But remember one thing, it's nothing better into the root canal space than a pulp tissue. It's better than any other obturation material. The inflammation, it's always related to the irritant, to the bacteria and their products. And if you have the bacteria, they will fail with the obturation material or with the pulp. Some pieces of the pulp will never harm dramatically, because you always have the pulp tissue inside left in the lateral canals, into the isthmus, or in some irregularities. Healing, somebody will say, well, we will leave the bacteria there. As we know, even with a very conservative preparation, here is the 20 ISO into the apex. You can see the healing. Here it's again 20 into the mesials, 25 on the distal. You can see at the 4 years recall there is a healing. So as Maestro Herbranson liked to say in his lectures, with the citation of the Nassim Nicholas Taleb, is that our ideas are sticky, so we are not likely to change our minds. And if somebody teached us that you need to enlarge up to this size and make that irrigation, or to obturate exactly in that way, it's difficult to change our mind. Even somebody will come and will support his ideas with the science, because our ideas, as Nassim Nicholas Taleb says, are sticky. Try to rethink your practice and to be more concerned onto the tooth preservation. Invest in yourself, be better. Invest in new tools, and not tools which create magic, tools which helps you to be more efficient, to be safe in preparation, to have a faster and more efficient access preparation. And I strongly suggest you to follow these guys on the social media, on the conferences worldwide. The guys who changed a lot of minds in terms of conservative dentistry, Maestro David Clark and John Academy, and my teacher and a very, very good friend, Dr. Viraj Vora from Canada. If you have an opportunity, just follow them. Invest in yourself, as I said previously. Read new things, think outside the box, and be better. And if you have any questions or something, feel free to contact me on the social media, on my email. Here you have my Instagram profile and Facebook. I hope this webinar helps you to change your mind. A special thanks to SSY that made it possible to share my experience and view on the conservative endodontics. And thanks once again for Dental Tribune to make it possible. Thank you, everyone. It was Eugen Buga. See you again soon. Bye.